Welcome. You're watching Channel 9 in Fairfield, Iowa, Public Access Television. I'm Susan Kessel, and with me today is Mary Saxton. And we're going to be talking about hospice. This is National Hospice Month. And Crossroads Home Care and Hospice is what we're talking about. Mary, thank you for coming.
Thank you for having me.
We've been wanting to do this show for some time, so this is spurred us on to doing it because it is Hospice Month. Hospice is a care for patients that is tries to keep them at home for the terminally ill.
Right, right.
How long have you been involved with hospice?
I've been in this position for about 2 years, and I'd been familiar with hospice because I've been a nurse for a long time, and familiar with it in other communities, but not really having the opportunity to work with it until the last 2 years.
And I know this is the first in our series, so we should explain when did hospice start, how did it start, the history.
Hospice in this country started in the 60s. It began as an initiative in England with woman who was a physician who somehow identified the fact that people were wanting to have a different experience as part of their life's journey, including the journey when they were dying. She identified that we had institutionalized much of our health care, living, birthing, dying, used to all take place in the home, and that we in Western medicine had turned it into an institutional sort of event and had taken away both the experience that families had at the time of birth and also the experience that families had at the time of death. So she began the hospice program in England, and in the 60s came here and I think initially met, on the East Coast, the sort of Eastern mecca of medicine, and began the whole hospice initiative on the East Coast, and then since that time it has come across the country. Now in Iowa, I think that there's probably been hospices, and I may not know the exact time, but probably for 20 years more, 25 years. And in southeast Iowa, the Fairfield had a volunteer hospice since the 80s, and it was begun by a woman who developed it as her RSI program when she was attending Iowa Wesleyan. And then there was also a volunteer hospice in Mount Pleasant, and that had been in existence for probably 15 years also. And then 2 years ago, we joined together, and they're no longer having volunteer hospices in either community, but they have put their enthusiasm and their support behind the program.
I remember a couple years ago when there was a reorganization, and then it came under the name Crossroads. Right. Was the home care there prior to this?
Yes.
And then it took on the hospice.
Right.
And that, for our area, is it a county area, or?
We serve Jefferson County, and then the counties that immediately surround those.
Okay.
Jefferson County. And sometimes I can remember all those counties, and sometimes I can't. But it's a 9-county area between both Henry County and that service area and Jefferson County and the service area.
And your headquarters are in Mount Pleasant, or your office?
The main business office.
Okay.
We have an office in Fairfield also.
Okay, so that explains why I call sometimes. I thought I had to call Mount Pleasant, but I didn't.
No.
It was here.
Yes, yes. We have nurses, registered nurses and home health aides who work out of this office and are from this community.
And that's at our local hospital.
Right.
How is this connected with the hospital?
The hospital, Jefferson County Hospital in Fairfield and Henry County Health Center in Mount Pleasant have a partnership. Okay. And so they support both of those hospitals support our agency.
Okay. Now, before it was totally volunteer?
Yes, it was.
And I know Bernita Pettit and some others were very involved and still are involved.
That's right. That's right.
But now there's maybe more organization to it.
Well, I would guess they were probably very organized before.
Oh, I'm sure they had to be.
The main difference is that we have become what's called Medicare-Certified. And what happens then is that Medicare will pay for a lot more services than in the past. Having it all be volunteer, insurance companies or Medicare may or may not pay for the full spectrum of what is provided in hospice care. And in most insurance companies or Medicare will pay for everything that is related to the terminal illness.
Okay.
Medications, equipment.
So this was a very smart move for the patient.
Yes, definitely. Definitely.
And so you are in Fairfield. What is your job? What do you do? Are you going to see people?
I don't go to see people.
Are you assigning families?
Yes. My primary responsibility is I'm the director of the program, and so I have responsibility for the stuff that's not really interesting with hospice. The good thing is that every once in a while I get to go to homes and maybe deliver supplies, or if
because
I'm on
you're
my
a
way.
nurse.
Yes, I am a nurse,
so.
and I can touch patients, but most of I have an administrative job more than.
Are you helping train volunteers?
Carol Moutry,
Yes.
who I believe will be on the program later,
Yes.
has primary responsibility
So
for
she actually trains?
yes, volunteer training.
Okay.
Yes.
Which is a whole nother process or step in
Right.
hospice.
Right, right.
So if, and we talked about this, or will, in another show, but if someone were wanting to contact you, what would they do? How would they know they need to?
They would know many times they know by either having a conversation with their physician, and their physician may identify that if they have a medical problem and there really isn't a lot of curative therapy that's available, that hospice still can provide a lot of comfort and support and therapeutic intervention that may not be technical as such. And so a physician may suggest that. Families, in the process of helping a loved one through an illness or a decline in their condition, may recognize that that's something that they are interested in. Knowing that hospice is available for people who are in a terminal phase or the end phase of the life cycle. So they can call us, and they can call a Fairfield number, they can call a Mount Pleasant number, they can speak to their physician who may make the contact. We'll take referrals from everyone, really, who's involved.
And then what happens after that?
Then we do need to speak with a physician. All of our care is really, there's a physician that provides some oversight as far as they would make what's called a determination that it is indeed a terminal illness, because there is a definition that is described by Medicare and other insurance companies that is a little scary for people, because it is defining a terminal illness and saying that if the disease follows its natural course, that it would indeed be terminal within 6 months. And so that really needs to have some medical oversight, and that's when a physician would be involved. Generally, the physician would help to design what the care needed to be for the patient, but most of it is really done by the nurse, the patient, the social worker, saying, what is it that you want? And helping them to be the ones that are in the decision-making process. A little bit differently than some medical interventions where the physician oftentimes is the decision maker. We really try to put the family and the patient as a decision maker.
Okay. I know that at a time when you're going through this, there's a lot of things to think about, and this is something that you deal with, and so you are the expert and know how to get them to the point they need to be. And they don't want to think of things like paperwork, and so you do that.
Yes.
Take care of all that.
Help them with that. I think that our lives are pretty complicated regularly, and then when we
I can remember paperwork. I'm dealing with some things with my own parents, and my goodness, I just don't know how anyone can deal with it.
Right, right, and it's very nice because we have a social worker on the staff who oftentimes will help with counseling issues, but also has expertise to help us through the maze of the paperwork that we have in our
I do want to
culture.
do another show with you on the home care because
That's the other piece that's complicated.
Yes, because of the paperwork, I felt like I was just guided along, directed, here and there, and knew that an expert was leading me.
Yes,
and I'm
yes.
sure this is the way here too.
Yes, it is interesting because there's less regulation for the family to have to deal with, I think, with hospice. When we first admit a patient, there are a number of forms that we have to complete. But once that's done, it's really pretty transparent to the family and the patient. And it's not as regulated as home care is.
So what the patient is seeing, and when you say admit, it's just to the hospice care.
Right.
They're staying home,
Yes,
and they
yes.
don't have to deal with any of that.
Right, right, right.
And so they are getting the care that they need. And what is some of that care? I know some of it is just being available, being there. If the caregiver needs a break, family member. What are some of the other things that they can do?
I think that there are, in the literature and even the media, newspapers, you see articles about people being so fearful of being uncomfortable and in pain during their last days. And I would say that we have expertise that there isn't any reason that people need to be uncomfortable and be in pain. The registered nurses have attended lots of classes and have a lot of expertise on helping people manage their pain, and it's a really important component.
So with the hospice, I know we will talk about the volunteers, and there are lots of volunteers, and they are not required to be nurses or anything. But also along with hospice, you have nurses that work with each family also.
Right.
Okay.
There's a registered nurse has a caseload, and so every family knows that one nurse is indeed their case manager or their nurse. And then we also have a team comprised of social worker, we have a medical director, chaplain, as you said, the volunteers. There's an opportunity to have home health aides, and with that team, we can provide a whole variety of support to the family. But the registered nurse is the one that probably is the core person, because they see the patient, understands both some of the psychosocial and also the physiological changes that people are going through.
So this is a whole team working together with the hospice when you have someone like that. I didn't realize that. That's really reassuring.
Yes.
So, because you've got different needs.
Definitely.
And they're all being met.
Definitely.
So, how many cases in the area have you been involved with?
We have had 115 patients in the last 2 years, and we have generally about at least two patients a day that are in the Fairfield area. And then I would say that's our average, and we've had certainly up to 5, I think, a day. And so if you just take that out.
So typically the team, say the nurse would be there once a week or more?
When
It
they
depends.
start, it's probably once a week. And again, it's sitting down with the family and the patient and saying, how do you think this will work? There are times that we start out with seeing the patient maybe once a week. There have been times when the family says, we're really pretty busy this week. Don't come by, which is what you really want them to do, be as involved and as active as they can be, as long as they can be. And the nurse doesn't have to be there. But so it may start as limited as once a week. There are times when things are changing pretty rapidly and they're there every day. But most oftentimes I'd say once or twice a week while people are pretty stable, and then as changes occur. Hospice can be delivered in a nursing home.
Oh, I didn't realize that either.
What generally happens is the nursing home just becomes their home, just becomes their place of residence. And so we would then still continue to provide hospice care, but instead of having a family, because some people don't have a family, then the employees of a nursing home would become the caregivers. It's not common. It's not, most of the care that we provide, I would say 95% is in the home, but there are those alternatives for people who don't have a primary caregiver at home. And then if people need to, if their symptoms become acute or something changes dramatically, they can, we have a contract with Jefferson County Hospital for patients to come into the hospital for symptom control. And the idea is that they would then be able to go home again, because not only do people want to have a comfortable death, they also, a big percentage of them want to be in control in their homes, and that's really what we try to do.
Oh, that's really important and a big job also. And I didn't realize that the home aides are available through hospice too.
Yes.
And that would mean if you're just being overwhelmed, you can have them come in and help you do maybe laundry or
or personal care. There are times when the intimate kinds of personal needs that a hospice patient may have just is more than the family or caregiver can manage. And so it might be that a home health aide will come in and help give a bath, or help to change linen, or those sorts of things. Because this, as much as families desire to do this, it becomes quite a responsibility. Yes. And so that's the piece that, that we can support them. The real stars and heroes of hospice are the families and the patients. And what we are able to do is just support them through that process.
Wow. That is a big job. So, and this is all covered by Medicare insurance. And that's nice to know, because I think a lot of people out there probably don't realize that.
That's right. I'm sure there are some policies that don't cover it. We don't make a decision to admit somebody or not admit somebody because of their ability to pay for this service. We admit people because they have embraced the hospice philosophy, which means they aren't seeking active treatment, and because they have a terminal illness, and then that they are really desiring to have this care at home and have a support system that can help provide it. But we don't make decisions on whether or not to accept them because of their ability to pay.
Okay, and once again we're talking with Mary Saxton, who is with the Crossroads Hospice and Home Care, and we're talking about hospice this month because it's National Hospice Month. Mary, is there anything else you'd like to tell us about hospice?
Oh, I'm sure there are hundreds of things, and it may or may not come to me immediately. But
and is this a growing endeavor?
Definitely. And it's growing across the country. So we're starting small and hoping that we'll see the trend to grow across the country too. I can't tell you what the numbers are, but I just read something that the amount of expenditures it was relating to Medicare expenditures has grown dramatically over the last 10 years. So people are accessing this service at the end of life and not feeling like they have to go it alone or have it be totally institutionalized.
Right. Well, thank you for sharing with us today about the hospice. And if you have any questions, you can contact the Crossroads Hospice and Home Care and
That's right.
The local Jefferson County Hospital.
And our number is 641-469-4280.
Thank you.
Thank you.
Thanks a lot, Mary.